Welcome to this educational web event sponsored by Dentsply Tulsa Dental Specialties. Please note there are controls at the bottom of the playback window that will allow you to pause and rewind the presentation as needed. This will enable you to get the most out of this discussion. Dr. David Landwehr is our presenter, and he's been compensated for this presentation. Over the next hour or so, he will offer a number of specific clinical suggestions that you can take into your practice tomorrow. In endodontics, the importance of adequately cleaning the canal space cannot be underestimated. The eradication of disease-causing pathogens is the first step. Creating an adequate obturation that prevents reinfection is also vital for predictable success. One cannot be thoroughly discussed without the other, and to that end, Dr. Landwehr will be discussing his irrigation protocol and how that ties into a canal filling technique rooted in science. Now, about Dr. David Landwehr. A Wisconsin native, Dr. Landwehr studied as an undergraduate at the University of Wisconsin-Madison and went on to earn his DDS at the University of Minnesota in 1994. From there, he completed dental training in 2 dental specialties. First, he earned an MS degree and a certificate in oral and maxillofacial pathology at The Ohio State University in 1997. He then completed specialty training in endodontics at the University of Michigan. Dr. Landwehr returned to Wisconsin in 1999 and has been in private practice since then. He's presented case studies and research findings both nationally and internationally. In addition, he has published several articles in various peer-reviewed journals and served as an evidence reviewer for the American Dental Association. Now, Dr. David Landwehr.
Thank you for the kind introduction. I am paid to be here by Tulsa Dental Specialties. It's an easy thing for me to do. I'm a free agent, okay? I use what I use for one reason and one reason only. I want to get the absolute best clinical outcomes that I can get. I'm not beholden to any file system, any instrumentation technique. I'm a private practice endodontist. I'm in the mouth 4 days a week, unless I'm doing something like this on a Friday, okay? So I want to use what's going to work the best for me. So it's an easy thing for me to do today. I'm just basically telling you my story, what I do, why I do it. We'll give you some science behind it and try to make decisions about whether or not we think that's valid. Okay, so please remember, as you integrate some of this new technology into your practice, there is a learning curve involved. It's not a steep learning curve. All right, all the clinical outcomes that I'm going to show today, they're all mine. Okay, if it's not my case, there'll be notation as to whose case it is. None of these things have been doctored or manipulated. I'm not smart enough to be able to Photoshop and do all that stuff that creative people do. Okay, so all the outcomes are legit. Let's talk a little bit about the science that we'll deal with. All right, irrigation. I see more microanatomy now than I ever have before. I gave the Wave 1 shape and the 08 taper in the final 3 millimeters a lot of credit as to creating that ability to get irrigant, disinfectant down to that level so we can see some of this microanatomy that exists. But that's not the only thing that's part of it. All right, so I think the irrigation and then ultimately obturation protocols matter as well. I don't think you can divorce one from the other. So if we look at this example tooth, of course, we're seeing some pretty good microanatomy. I didn't have an instrument in there. I did not have an instrument in there, but ultimately we had disinfectant in there, and it's sealed to the apex. So this is the old how are we doing to check in with you guys, but it's not really how are we doing to check in with you guys. It's how are we doing in general, okay? So if we look at success, failure studies, long-term studies, the bottom line is we're doing okay, but we're not doing any better than we did 30 or 40 years ago. So all of these technological advancements that I've talked to you about today, we haven't changed our long-term success rates one bit. We've made it a heck of a lot easier. It's more efficient. It's probably cleaner. I suggest we're treating a lot of teeth today that are going into the success column that maybe were never treated before, that we're treating harder teeth, more complicated teeth, and that's going to impact our success rates. But the bottom line is our success has been pretty flat. right? And I think we'd all like to see that go up. So this is a study from Peters et al. Instrumentation of the root canal leaves 35% of the canal wall untouched. 35%. That means 35% of the biofilm that's there, we may not be doing anything about it. And that, of course, is a concern. So we need to try to find ways to get rid of biofilm to kill bugs, to enhance our clinical success. So this is a whole array of studies, one after another, looking at different irrigation protocols, instrumentation protocols, different ways of trying to get rid of bacteria in the root canal system, photon-initiated photoacoustic streaming, laser, ultrasonic, and all of these studies as they go by behind me, all of them find the same thing: a statistically significant reduction in bacteria, but not a complete elimination. Okay, so what does statistically significant mean? We don't know what it means in the clinical setting, right? But what we do know is we want to get rid of as many bacteria as we possibly can. And we know we don't get rid of all of them given current technology. So what are some options to help us get rid of bacteria? Again, lots of things have been tried. Okay? I think the protocol that I'm using currently has a combination of being really simple and yet highly efficient and effective. And that's sort of what has allowed me to gravitate in that direction. The Hess picture from earlier that I showed you all the way back in 1925. So we've known about this anatomy. Now we're trying to get to the point where we can do something about this anatomy. So what are we really talking about? We're talking about bacteria. It's what we've been talking about all day long. We're talking about bacteria in the root canal system that eventually lead to these changes outside the root canal system. Now, are there bugs on the outside of the root canal system? At this level of the tooth, right here on the outside, do these bacteria exist? Highly debatable. In some studies, yes. In many studies, no. So what we're really dealing with, where do we know they're located? Inside the tooth. Those are the ones that we can get at. Those are the ones that we're trying to affect when we're doing a root canal treatment. So we look at some pretty straightforward teeth, heavily restored, and the bottom line is we never know where that extra anatomy is lurking. So we have to assume that it's there each time and every time. We're dealing with biofilms. We're not dealing with bacteria in the truest sense of just bugs for bugs. These bugs, when we're talking about biofilm, we're talking about something that's very, very complex. So what does that mean? Well, these bugs will stack up 8, 10 layers thick. Of course, that's going to confer an advantage to the bacteria that are underneath. Some bacteria create a byproduct as they metabolize sugar or what have you. This metabolic byproduct is used by some other bacteria in the neighborhood to gain a growth advantage. Some bacteria can transfer RNA to others, thereby promoting antibiotic resistance. So it's a very complex community and microenvironment, bacteria communicating with one another, finding growth advantage, making it much more dicey for us to come in and just get rid of them. Okay? So they like to live in biofilms. They move around in the planktonic or free-floating state. But when they're attached, they're going to be talking to one another and communicating. So this is this morning after I woke up and forgot to brush my teeth, of course. This is the prototypical biofilm, bacterial plaque. All right, so what do we want to accomplish when we're irrigating the root canal system? We want to debride tissue, right? Dissolve pulp, remnants of pulp. We want to kill bacteria. That's by far and away the most important thing from my perspective. And we also want to remove the smear layer. The smear layer is basically the byproduct of what we do. So I showed you the debris on the file as I was doing that instrumentation. Some of that debris is coating the canal wall. Some of that debris gets pushed into the dental tubules in the clinical setting. So we want to get rid of the bacteria. We also want to get rid of that smear layer that we create as a byproduct of our instrumentation. So how do we do it? We talked about hypochlorite already. Hypochlorite for me early and often is the way I want to go. Hypochlorite is going to dissolve tissue and kill bugs. That's what we want. That's what makes it the best irrigant from my perspective. Okay? Dissolve tissue, kill bugs. But what's the concern? The concern is that the hippies and the freaks in Madison don't like how it smells very much. It smells a lot like a swimming pool, and that's okay. It also may have some deleterious effects on the dentin. Okay? So if it's around long enough, we may be causing some change in the dentin structure. That's a concern from my perspective. EDTA. EDTA is used to remove the smear layer. EDTA does not kill bugs. So it's used to remove smear layer, and that's it. It's not dissolving tissue, and it also may have some impact on the dentin if exposed to the dentin for any extended period of time. Chlorhexidine has been promoted by some to be a very effective irrigant because it does kill bugs. Not quite as fast as hypochlorite. It does not dissolve tissue. That to me makes it, that's the limiter. It's not removing any tissue or dissolving tissue. So that's what prevents me from going to chlorhexidine as my irrigant of choice. That said, if I have an isolation issue, so the rubber dam is in place, but it's a very carious, broken down distal aspect of a lower molar, I may consider using chlorhexidine in that case. What I won't do is use bleach and chlorhexidine concurrently in the same case because I'm concerned about creating the precipitate that we'll talk about in a few minutes. So at the start of treatment, I'll make a decision. What is my isolation? Do I want to use chlorhexidine, or is this going to be my standard hypochlorite irrigation type case? So the most common techniques. From an endodontist perspective, we want to kill bugs, we want to dissolve tissue, we want to remove smear layer. And after we remove smear, it's very important then that we kill bugs again. We're opening up the tubules, and the idea is to then be able to get disinfectant where we've never been able to get it before so that we can get that final kill. So the combination of bleach, EDTA, and bleach is the most common irrigating regimen out there. That said, I think we can do a little bit better, and we'll talk about that in a couple of minutes. If we look at the smear layer in the coronal, middle, and apical thirds of the root canal, that's the debris that we're creating in the process of cleaning and shaping the root canal. So we want to remove smear layer. If we look again at coronal, middle, and apical thirds, removing smear layer with EDTA is opening up all of those tubules. Now, there are not very many tubes in the apical third of this section. And in many teeth, there are not very many tubules in the apical third. Thank goodness. The more tubes that are in the apical third or any place, the more potential places there are for bacteria to remain within the root canal system. Okay, so the natural anatomy, the lack of tubes in the apical third is a big positive. Now, some teeth have a lot of tubes in the apical third. This individual section did not. So using hypochlorite after an acid rinse, whether it's EDTA or citric acid, can potentially cause some issues with dentin, and that's concerning to me. So if we look at dentin, healthy, happy dentin with hypochlorite and EDTA, that looks great. So there's no erosion or issues there. But if we throw some bleach on top of that, we're starting to see some erosion of the peritubular dentin, and that's a concern. Okay, so I don't want to do anything that's going to change the physical or mechanical properties of the tooth. So up to this point, really no irrigant, no one thing is going to fulfill all of our required tasks of killing bugs and removing smear layer. And that's up until now. So my final irrigation protocol now includes QMix in each case, every case. Vital, necrotic, retreat, anterior tooth, molar tooth, doesn't matter. Each time, every time, because of the things that we'll talk about as we go through. So QMix is chlorhexidine, so it kills bugs. It's EDTA, so it removes smear layer. And it has a surfactant or a detergent which allows for deeper penetration. It decreases the surface tension of the fluid, hopefully allowing it to get into all of the nooks and crannies within the root canal system. So the common practices following hypochlorite are to remove smear layer and then disinfect with a final rinse. The idea behind QMix is to do this simultaneously all at once. So the idea is to combine steps, hopefully requiring less chair time. Quite honestly, after going through all of the effort to create the shape and cleanliness that we've created in the root canal system, if it took a little bit longer than what we were doing currently, I wouldn't care. The fact that it's more efficient is an added bonus. All I care about at this point, I just want to kill bacteria. You know, I want to exterminate as many bacteria and remove smear layer from the inside of the tooth. So if this is going to do that better than what I've got, and it's not going to change the dentin like what I might have been doing, then I'm all for it. That's why I use this. Okay, so what do we see? We see a comparable smear layer removal as to EDTA. We also see a very efficient and effective killing of bacteria, and it's simple and easy to use. So if we look at the Pashley study, QMix and measuring smear layer removal, QMix and EDTA are comparable in their smear layer removal. So they're both very efficient ways of removing smear layer. If we look at QMix and bacteria, QMix is also as effective as hypochlorite at killing bacteria, more effective than chlorhexidine or MTAD, and an effective smear layer removal. And we're talking about Enterococcus faecalis in this study. That's sort of our prototypical bug in endodontics. Enterococcus faecalis is around in many retreatment cases. So we think of it as a very hardy and fastidious bug that's difficult to kill, and that's why we think it's around in lots of retreatment cases. Enterococcus faecalis is unique in the fact that it can go into a nutrient-starved state. So it can basically linger inside the tooth, alive but sort of in suspended animation, and when it has a nutrient source again, can sort of come out of that nutrient-starved state, and as a result, we really want to know that we can kill this particular bug, and QMix can do it. So if we look at QMix smear layer removal, we see open tubes in the coronal middle and apical thirds. Now this apical third section had a lot of tubes, many more than what we saw with that first section. That's just anatomical variability. But what you see is a very effective smear layer removal at every level. If we look at EDTA and dentin surface against QMix, I think that QMix surface on the right looks a little bit healthier than the QMix or than the EDTA does on the left. If we think about mixing some of these things together, what are our concerns? Chlorhexidine and EDTA makes a salt precipitate. Chlorhexidine and sodium hypochlorite makes chloroaniline, parachloroaniline, which looks like this brown precipitate here. Here's chlorhexidine and EDTA making a salt precipitate. I don't want to put anything together in the root canal system that's going to make something inside the tooth that I then need to worry about getting back out. The concern with the parachloroaniline is that it may be carcinogenic. I certainly don't want to put a carcinogen in the tooth. Okay? So if you're someone that's saying, well, heck with this QMix stuff, I'll just put in some, he said put some chlorhexidine in there and some bleach in there and it's all the same stuff. Well, it's not the same stuff because the chemistry is different. Okay? The chemistry is different to prevent that precipitate from forming. So if we look at QMix and hypochlorite, we don't get the precipitate. That's the point. If we look 24 hours later, the parachloroaniline precipitate is still there, while the chlorhexidine and EDTA salt precipitate has sort of settled out. Okay, so just to review QMix, basically we're getting disinfection, we're killing bugs, we're removing smear layer. It's simple, it's efficient to use. Comes in a couple of different ways. 60 to 90 second working time doesn't mean you have to get it in the tooth and get it out of the tooth in 60 to 90 seconds or the tooth is going to blow up. Okay? 60 to 90 second working time means we want it in the canal for that period of time. While it's in the canal, we might be doing some stuff to it, like activating it, spinning it around. In essence, a mini cocktail swizzle stick. All right, and you get to see that in a minute. So the protocol for QMix, final hypochlorite rinse. So hypochlorite early, often, all the time. I've got my final shape. I'm ready to think about sealing the canal spaces. I'm going to pull out the hypochlorite. There's a water rinse that occurs after that hypochlorite has been activated. So the hypochlorite's doing its thing. It's activated with the swizzle stick. It comes out. Some distilled water, sterile water goes in to try and make sure that there's no active component left to the hypochlorite. It comes out, and the QMix goes in. If I'm doing a Guttacore case, I will likely size verify at this point. We're going to activate the QMix. Again, stirring it around, agitating it as much as we can. We want to disrupt biofilm. We want to kill bugs. The canals are dried and sealed. Okay, so it's really used as a final rinse. It's the final thing that's in the tooth before sealer and Guttapercha. So when we talk about activation, this is the endo activator. And if it had batteries in it, it would spin around. Okay, so when I have the final shape and cleanliness and hypochlorite is in, the canal is activated. That's a tooth that's ready for activation. This is a sort of what it looks like post-activation. So if you look at how clean that looks, and it does look clean, post-activation we see all of these bubbles, and it takes on this sort of grayish, cloudy appearance, like we've pulled out debris and stuff that was along the canal walls. It's pretty impressive to see in some instances. If we think about what it looks like down in the black, we're creating all of these bubbles and just dispersing the hypochlorite and really trying to pull out debris, making sure we have as clean a surface as possible. So if we look at activation and a couple of studies there, the Florida group, better obturation of lateral and accessory canals. That's the study that I can use to back up what I told you anecdotally. I see more microanatomy now than I ever have before. Well, maybe it's because of the activation protocol as well. If we look at activation, the French group, same deal, removing smear layer. Cleanliness benefits from activating solutions. It's intuitive. It makes common sense. If we're doing more to activate and agitate the disinfectant, we should be making a cleaner canal system. All right. Questions about QMix, irrigation protocols? Why, how, where?
How long do you activate in each canal?
Yeah, so the question is, how long do I activate in each canal? And I get that question every single time, and I don't put it into the presentation because I want that question. The activation that I do is case specific. So what that means is I don't have the answer for you. I wish I did. I could tell you it's a minute. I could tell you it's 90 seconds. It's different in each tooth. So if it's a nasty, really smelly retreatment tooth, I'm going to activate it for a really long time. Okay, so it's variable depending on what my purpose and goal is.
You mentioned that you were concerned about putting something in the canal that could be carcinogenic.
Yeah. The precipitate for perchloroaniline, although it's probably not carcinogenic, at one time there was certainly concern that it could be that this precipitate that's made with the combination of sodium hypochlorite and chlorhexidine potentially being a carcinogen.
So it's a carcinogenic because it's traveling through the dental tubules out?
No, we're not, no, in general, not unlike cigarette smoke is carcinogenic, right? So just because it can do it doesn't mean it will do it. Lots of smokers don't get cancer. Okay, so the point is, just so we're clear, I don't want to put anything in the tooth that I have to worry about taking back out, whether it's carcinogenic or not. I don't want any brown sludge on the inside of the tooth that's going to impact the quality of my seal and root canal filling. It's just that simple. Does that make sense?
It makes perfectly good sense.
Mm-hmm.
But why then wouldn't the chlorhexidine that if it's your last rinse, you're leaving in there?
QMix is my last rinse. The QMix is the last rinse. It has chlorhexidine in it, but it's a different chemistry.
Why? Go ahead.
The differing chemistry. So I showed you the vial of the of the QMix and hypochlorite. It doesn't make a precipitate.
Before there was QMix, many people used the chlorhexidine as their final rinse.
Right.
Correct?
Right.
Why wouldn't this chlorhexidine infiltrate some of the fins and other things that are in the root canal system that we can't get out?
Well, it absolutely would. That's the problem. That's an advantage and a disadvantage at the same time. It's getting there, it's potentially killing bugs, but if it's making a precipitate and you've got brown sludge in these inaccessible areas, then you have to decide, do you want precipitate there, or would you rather have what was there naturally? I don't know that we know the answer. Ideally, I think we'd both agree that we'd like to have everything out and everything sealed. Realistically, given the microanatomy of the tooth, that's not likely possible.
But you don't have to combine your chlorhexidine and sodium hypochlorite at the same time. If your last rinse before the chlorhexidine is water, you've dispersed the bleach, correct?
Yes and no. Yes, in the accessible areas.
I'm not trying
no everywhere else. That's the problem.
I'm not trying to be argumentative.
Yeah. It's yes and no at the same time.
Okay.
So not in those inaccessible areas. So I mean, I had this discussion with someone a couple of weeks ago. He said, I put in as my final rinse chlorhexidine after I've used bleach throughout the procedure. And he then said, I pull out with some paper points until the paper points are clean. Great. That means that the canal that part of the canal that he is gaining access to with those paper points maybe doesn't have the brown precipitate. But all the other parts that he's not getting at do. Yeah. So I don't know why you'd want to make the precipitate if you had the same chemistry, the same advantages, but different chemistry, same advantages, and we're able to remove the smear and kill the bugs. It just seems, yeah, just seems more intuitive from my perspective. Right. But it had shortcomings, and that's the reason for the advancements.
Sure.
Yeah. Okay. Good? Other questions? We've got it diagnosed, opened, cleaned, disinfected. The smear layer is gone. We've got to put a white line in. So let's do that. Obturation. Obturation with Guttacore carriers, and we'll talk about obturation in general as well. Let's put some pink material and make some white lines into the root canal so we're finally done. So from my perspective, obturation means absolutely nothing without a clean canal. We have to clean the canal before the white line matters. We talked about it earlier. I showed you a couple of cases. I showed you how unimportant obturating the root canal system was. Really impressive bone healing in the absence of any white line on the inside of the tooth. Why? Because it was clean. But that's not going to withstand the test of time because we know we can't clean out all of the bacteria. We've decided we're not able to sterilize the root canal system. And if we move forward and we look at the Delevannis study, cleaning and sealing the root canal system, super important. Old school mentality, if we leave bacteria behind and we trap them with the root canal filling, we're okay. But I just talked to you a few minutes ago about Enterococcus faecalis, where we can trap and entomb, and it's just waiting to come back and get us at some point down the road. So trapping and entombing, like we talked about back in the 80s, may not be a fair way of evaluating obturation. Okay? If we look at factors that are critical to get long-term healing and success, this is a review looking at all sorts of factors related to root canals and root canal treatment. We talked about how obturating the canal may not be the most important thing given the cleanliness earlier today. However, if we look here, these are the factors that are important. Lack of a preoperative lesion. That's got nothing to do with what we're really talking about right now, but all of the others do. Adequate coronal restoration. I think of the root canal filling as the first step of the coronal seal. No voids within the root canal filling and a fill within 2 millimeters of the apex. So all of the things that were important that we could evaluate in this study indicate how important and critical obturating the root canal really is. If we look at how root canals are filled up, if we look at the method of obturation and we make comparisons in all of the things that we do, there's really not a big difference technique to technique. That goes back to what we've talked about earlier. Cleaning the root canal system is the most important. If we get the bugs out, then our filling, although important, is likely to be successful irrespective of technique. Now, I think there are better ways to fill different teeth, different cases, but if we look at the studies, there's really no one technique that consistently comes back better compared to any of the others. So the characteristics of an ideal filling: we want a 3D fill, top to bottom. The shape should reflect the continuous taper. Again, taking the filling, sealing the canal space, which we've taken such great care to enlarge slightly at every dimension. So a shaped canal, a sealed canal. We want a dense filling top to bottom, and we'd like to keep all of the filling material within the root canal system itself, if possible. So there are lots of different techniques that have been employed to fill the root canal system. Whenever I see a list like this, things that have been done historically, it sort of says to me there isn't one ideal way. Because if there was one ideal way, we'd be doing that. We wouldn't need so many different options. So historically, cold lateral condensation was how I was taught to fill root canals when I was in dental school. It's a very long-standing traditional technique. There is nothing wrong with cold lateral condensation. It involves fitting a master cone to the root end, creating lateral pressure for room so more Guttapercha can be put into the root canal system. Downside of cold lateral condensation is it requires a lot of lateral force. We get concerned about the potential to crack teeth. It also is a technique that, because, let's go back for a second. Cold lateral, we have to create lateral pressure, a little concern about a crack, but as we create that lateral pressure, we're not really getting the lateral hydraulics that we're looking for to fill and seal microanatomy. So it's really good for those canal spaces where it's simply a tube from the top to the bottom. But we already decided earlier that many canal spaces are not a tube that run from the top to the bottom. We want to fill any microanatomy that's there, and this is a technique that probably doesn't do very well at that. If we look at warm vertical condensation, this is a technique that I employ in my practice every single day. So after I've created cleanliness and shape, we fit a master cone to the root apex, and then with heat, we're removing Guttapercha to within a few millimeters of the apex. so that we thermoplasticize the Guttapercha throughout. What this allows us to do is then laterally seal any microanatomy that's present, and a backfill is used to seal the remaining portion of the canal. Downside, you've got to have enough shape to be able to deliver the heat source to the root end. Otherwise, it's in essence a single cone. So we've got to have enough shape to thermoplasticize the Guttapercha, and from my perspective, it's a technique that I could not do unless I have direct line of sight. So it's a technique that you need to be able to visualize the inside of the canal system. If you can't do that, then I don't think this is a very good technique. That leaves us with carrier-based obturation. The advantage, big time, is that we can take warm Guttapercha to the apex without having to get a heat source to the apex. So we can get all of the advantages of the hydraulics of the Guttapercha that's warm without having to force a heat source or plugger down to that level. Now, carrier-based obturation has been around for a while. One of the big positives is that it creates a very tight, good seal. Lots of Guttapercha, very little sealer. That's exactly what we want. But there are other issues that were associated with earlier generation carrier-based techniques where an overall lack of cleanliness, not getting rid of the bacteria, was made to be worse by jamming in a filling material that made it look like a white line, right? Really dense white line, looks really clean, but not clean. So in essence, an optical illusion of cleanliness. If we look at carrier-based obturation, carrier system thermofill produces a higher percentage of Guttapercha filled area. That's what we want. We want a lot of Guttapercha. We want the tightest possible seal compared to system B or lateral condensation. So carrier-based techniques have the potential, when used appropriately, to be a really, really effective way of sealing the root canal system. So when we're talking about Guttapercha, we're talking about 1,4-trans polyisoprene. It's an isomer of rubber, in essence. That's why when we heat it and thermoplasticize, it will move. It comes in two phases, beta and alpha. The beta phase is what we see as a cone of Guttapercha. The alpha phase is what's on the outside of a carrier that will heat and take on a little bit less viscosity, flow, and move. Because of cooling with the Guttapercha, condensation pressure is required to prevent shrinkage. That's one downside of Guttapercha. And it's definitely biocompatible. If you take a piece of Guttapercha and you put it sub-Q under a rabbit skin, they make a fibrous capsule. There isn't an inflammatory response to Guttapercha. Let's talk about monoblocks for a second. I told you earlier about 25% of what I do is retreatments. And from my perspective, I like to retreat teeth that were resin-filled. Resin-filled root canals, from my perspective, are not tight seals. When we open back into those, we oftentimes see this sort of gray, it almost looks like gray pudding on the inside of the tooth. It's very easy to remove. It hasn't created the seal, the monoblock that they describe. When we look at sealer-based techniques where basically a master cone is used to pump in sealer, the design is to create, again, a monoblock of sealer. If we think about the anatomy in the root canal that I showed you earlier, if we think about what we do when we're doing a composite and we put those two things together, I think the monoblock concept is a hard concept to think about as a successful one for filling the root canal. If we're doing a composite and we get a little bit of moisture on our cavos surface, what happens? It doesn't bond. I showed you all that anatomy. We're not going to be able to bond to all of those nooks and crannies where there's still potentially tissue, bacteria, all of these other places. So conceptually, that technique, those two techniques, don't really seem to work very well in my mind. That's why I'm a Guttapercha guy, okay? So obturation. This is a Guttacore carrier. The initial generation was gray, but with evolution of the material, it's now a pink carrier. If we look at a couple of clinical cases, we're looking at teeth 4 and 5, and we'll just bring up the fills. Is it obvious to anyone in the room what tooth is filled with Guttacore and what tooth is filled with warm vertical condensation and a Obtura backfill? That's the answer right there. The fact that all the hands don't go up and there isn't vitriol in the room. You can't tell. Okay? We see some microanatomy here. That would suggest that maybe that's a carrier-based technique. We see a little puff of, or a big puff, depending on your description, of sealer there, which suggests maybe that's a carrier-based technique. So tooth number 4 is a System B warm vertical downpack and Obtura backfill. Tooth number 5 are Guttacore carriers. For the most part, they're pretty identical. The shapes are pretty close to the same, and the quality of the seal, I think, is pretty close to the same. How about this one? Anything obvious that suggests one technique over another there? No, I think it's the same thing. Tooth number 31 is the Guttacore case. Why? Under the microscope. I showed you all that anatomy earlier today. And under the microscope, I could see a little fin. I couldn't get into anything clinically. I couldn't probe into anything with small files. But I felt like there might be some interconnection or communication between the mesial buccal and mesial lingual canal. I wanted maximum hydraulics at every level as I sealed. And if you look really closely, right here, I think there is some interconnection. I'm not sure I would be able to get that with any other technique. Okay, that's what's going to make this technique my filling of choice when this type of anatomy presents. So carrier-based obturation. The problems with carrier-based obturation: difficult to retreat or remove material. So if it was an older technique like thermofill, the plastic or initially metal carriers were very, very difficult to remove. As a result, difficult also to create post space. Because they were stiff, very rigid carriers, you could take a very small space that was not cleaned, jam in the carrier, and again, create that optical illusion of cleanliness. A dense white line. But it's really the resilience of the carrier that allowed that, not the cleanliness of the canal. And that's a problem, because then all those bacteria are still present inside the tooth. I gave you the study earlier that showed how much Guttapercha is there. So it's a very good technique in that respect. Good seal, lots of Guttapercha. Very good for difficult anatomies, the long, curved, narrow spaces, because you don't need to deliver the heat source all the way down to the root end. So why Guttacore? What's the advantage? It basically takes all of the disadvantages that I just gave you of thermofill and other carrier-based systems and addresses them directly. So we can create a filling material that's Guttapercha through and through. So when I showed you the carrier before, it's all Guttapercha, and we'll talk about that more in just a minute. So it's Guttapercha through and through, so it's sort of what we know. It's what we've used. It's what we're comfortable with. It requires improved shaping compared to previous carrier-based techniques because the resiliency of the carrier is not the same. What that means is if you don't have the shape, it simply won't go. So I get the question all the time. I'm having trouble with my fill this way, I'm having trouble with my fill that way, and as I alluded to you earlier today, I said a lot of times it's not an issue with the fill, it's more an issue with the shape. If you don't have the shape, it won't go. That's why I think the wave 1 is so compelling when we're talking about obturation, because if you have a wave 1 to the apex and you've created your shape that way, you have the shape. Now, we don't know exactly what size carrier it will be. It might be a 25. It might be a 30. But you will have the shape to get a carrier into a clean root canal to create the best possible seal. Because it is Guttapercha through and through, it's much more amenable to removal and the creation of post space. So those limiters with thermofill are not as relevant. Okay? So what is Guttacore? So here we see a carrier. There's our stopper. That right there, the stopper, is the only thing that isn't Guttapercha. Everything else, the handle, the carrier itself, and the alpha phase Guttapercha on the outside, all Guttapercha. So cross-linking of Guttacore is what makes it unique. Basically, an activator is added, some energy is added, and what happens is the carrier doesn't melt. What that means is if you're trying to create post space after placement and you're going to use a heat source to do it, I wish you good luck. You can't melt it. It doesn't melt. It's like ice that won't melt. Okay? So it's got this modification to it. It doesn't melt because of how it's activated. The only way you can remove it is mechanically. But the good news is it comes out very efficiently mechanically. It's very easy to remove using rotary instruments. So again, Guttapercha all the way. The only thing that isn't is the rubber stopper. So the Guttapercha itself has been transformed. As it's placed, it's going to create a very good hydraulic seal, centrally condensing, moving out laterally, creating the best, tightest three-dimensional seal possible. And if we come up short, or we need to create some post space, or we simply just want to try it again because it didn't look exactly how we wanted it, it removes very easily. So let's talk a bit about technique. Final shape. I said it's mandatory that you have enough shape in order to be able to place the carrier where it needs to go. If you don't have the shape, and I can't emphasize this enough, it's not going to go. You can't force it down. You can't cheat the technique. So I suggest that you have at least a 2506 shape. You don't need that. You can get there with a 2504 shape. But if it's a 2504 shape, it's likely going to be a size 20 carrier. So if you're using an instrumentation technique that's an 04 taper, the size that you create at the apex with your instrument will likely be one size bigger than the carrier that will go comfortably to the working length. So if it's a 3004, it's likely going to be a size 25 carrier. The carriers themselves come in size 20 to 90, so you do have a lot of flexibility in size. Okay? So it's really important that you have the shape. I can't emphasize it enough. But if you're committed to doing wave 1 shapes, you have it. That's sort of the joy of this and how it all fits and works together. Okay, so how do we do it? It's really critical, imperative, that the size be verified. We want to pick the carrier that fits the canal. How is this done? In the pack that you get the Guttacore in, there is a size verifier. It's nickel titanium. It's active. What active means is if your working length is 20 millimeters and you're size verifying a 30 Guttacore carrier, because you've had a wave 1 in, 2508 at the tip, and at 19.5 you meet a little bit of resistance. You can give a little spin, activate the file just a little bit, enhance that shape, and that will likely be the best, tightest fit. My guess is in that clinical scenario, and I see this all the time, is that a 25 would feel too loose. That your 25 size verifier would want to go beyond the working length. So by just tweaking with the size verifier slightly, you can create the ideal shape for that carrier that you're going to place. Okay? So the size verifier goes in, it's placed, there's just a 180-degree rotation. You just want to make sure it fits passively, comfortably, not too big, not too small, just right. Okay? So dry the canal with the paper point, sealer, seal. This is a concept that gets a little bit confusing to folks because the carrier has Guttapercha at the end of it. It doesn't flush to the end of the carrier. So how you determine where to set the stopper is a little bit different than what we're used to. So if your working length is 20, it's from the 20 top of the stop on the carrier. not bottom of the stop. And that's because of where the Guttapercha is at the carrier end, beyond the carrier. We want Guttapercha, the alpha phase Guttapercha, to be creating the seal, not the carrier itself. Okay, so it's top of stop, not bottom of stop. Or you could do what I do. Probably won't get you in too much trouble in this scenario. You could go 19 millimeters from the bottom of the stopper. The stopper's 1 millimeter. Okay, so 20 millimeters top of stop, 19 millimeters bottom of stop. Either way gets you to the same point. So I just take 1 millimeter off of my working length and go to the bottom of the stopper. But either way will work. So there are calibration rings at every level of the carrier above the level of the Guttapercha at 18, 19, 20, 22, 24, 27, and 29. So in those really long ones, you can use those rings to help you figure out where you want to place this. Let's take a video and show you size verification. Only after everything is done do we size verify. The canal is completely dry. And we're size verifying with a 25 in the mesial buccal. So it goes into working length. It's sitting right on our reference point, and just a little spin around. And back out. Same thing in the mesial lingual. Sealer. When you have in the right amount of sealer, you have in way too much sealer. When you think you have far too little sealer, you have the right amount. Why? Because you'll be creating the best, tightest seal you've ever created before. More Guttapercha than ever before. More Guttapercha means less sealer required. Okay? So there's definitely learning curve here. Really try to limit the amount of sealer. You do not need a tremendous amount of sealer. You need very, very little. How do I know when I feel I have the right amount of sealer? When I put the sealer in and I take out with paper points, typically not one paper point, but one, look at it, another, look at it, and it looks like there's very little or no sealer coming back out, and I look in the canal under the microscope and it looks like there's just a very small amount inside, that's what I think is the right amount. So a very small amount of sealer required in order to use this technique. You want to pull out any excess. So placing sealer in with a paper point into the mesial buccal canal. Just a little bit of pumping action. We do want to move it around. I do want to coat the entire canal surface if possible. And then with a series of paper points, I'm going to bring that back out. And it should look pretty clean. Same thing then in the mesial lingual canal. And I would go just a little bit more there. I would check out just a wee bit more than what the video shows. And now the same thing in the distal. But you can see the effort that's made to coat the entire canal surface, even though that's quite a bit now, and now pulling more out. And again, I would blot off that extra at the orifice level. Just want a very thin coat all the way. Now, as the carrier is placed, the important thing to notice here is how slow it goes in. It doesn't need to be rapid and aggressive placement. When you think you're going too slow, you're going just right to the apex. The other thing I would do clinically that's just a little different than the video shows, there would be a paper point in the mesial lingual canal to prevent any gutta-percha from going over and clogging that orifice, just making it a little bit easier to prevent any blockage right here. And again, now you can see this one's being placed with a cotton pliers, facilitating access, and that is my method of choice. So when it comes out of the oven, I'll grab it with the cotton pliers, break the handle, and place this way. It provides just that extra few millimeters of access so the handle isn't getting in the way. We can see that the carrier is being severed with a sharp spoon. And removing a little bit of the extra gutta-percha. Now in the distal canal, that's quite broad, facial lingual. So as the carrier goes into the distal canal, there's going to be a little bit of condensation and downpacking that you're seeing here as well with the mesial lingual. So handle removal, there's a couple of different ways that it can be done. It can be done simply by bending. You saw the sharp spoon. It can be done with a small round burr as well. Small round burr is actually becoming my preferred method of choice. Initially, I was a sharp spoon guy. I'm finding that the small round burr, for whatever reason, it just is working a little bit better for me. So there are a variety of ways that the handle can be removed. This is what I'm sort of gravitating towards, is the small burr. So if we watch placement into the distal, you can see where the sealer was from before. So critical to match the size verifier to the size core that you're placing. Nice, slow, smooth, steady placement. And now we'll see this being severed again. And you can see that there is quite an abundance of gutta-percha. There's a lot of gutta-percha there. You're in essence filling a quart-sized jug with a gallon of fluid. That's how you create a tight seal. And all of that gutta-percha is cleaned up at the chamber level. To create post space, it can be done with whatever post system you use, as long as it's not a heat-driven system. If you use something that creates friction or heat as your means of removing gutta-percha, again, it's not going to be effective. So something that's mechanical and rotary, it can be a Gates-Glidden burr, it can be just a post drill. So there are a variety of ways that it can be done. And it comes out very easily. It comes out just like Gutta-percha does. So if you were in the past a cold lateral condensation person and you remember removing a segment of Gutta-percha to create post space using that filling technique, you'll find out that the Guttacore comes out in a very similar manner to that. We'll watch it happen. So you can see the chamber has been cleaned up following placement. So pretty straightforward. And post in. Okay, so if we're not happy with the placement and we want to remove it, or we're retreating, or we're doing something else, rotary file that you use to create the final shape, the final cleanliness, will likely zip out this carrier very easily. You can use some solvent around the Guttapercha to soften if you would want to. I've not found that that's absolutely necessary. Again, what you can't use is heat. Heat is not going to help you. So here we see a series of ProTaper retreatment files. We won't go through the whole series, but what you will see is that the file engages the Guttapercha, and it comes out just like Guttapercha, even though it's core carrier based, Guttacore carrier. Okay, we won't belabor that. So if we look at the ease at which this can be removed, Guttacore is removed in less time in curved canals than with ProTaper files than either thermoplasticized warm vertical condensation or thermofill. And of course, the fact that it comes out easier than thermofill is absolutely no surprise because the carrier is so different. Okay? So how to use the oven? It's pretty straightforward. You all have one in front of you. You place the carrier in, it goes down. We've got on-off button. We'll do a little video here in a moment. So it just goes down for several seconds. The important thing to remember is where you place the rubber stopper below the level of the handle. Let's look at a couple cases. So this is from Dr. Larry Farsakian. He's in Chicago. He had some issues with a pretty sharp and double curve to the distal and the facial in the distal root of this lower molar, not able to pass files predictably around that tight anatomy. So he used Guttacore in this case. You can see that it's long and narrow and tight anatomy here. And he's able to get sealer and or Guttapercha to wrap around that curve. I think that's pretty impressive hydraulics, certainly increasing the likelihood for healing and long-term success. This is from Dr. Bill Nudera, also in Chicago. Here we see Guttacore carriers placed to the apex following a wave 1 instrumentation, and you see two final images with a barrier at the orifice level to enhance the coronal seal. Dr. Scott Doyle in Minneapolis, this is a radix entomolaris. So these are very, very difficult to treat in many instances because that root is going very much lingual and wrapping around, big curve, tight anatomy. And that's what Guttacore is absolutely ideal for. There's no way he'd be able to get a heat source down to the apical third of this root. Physically not possible. And there's his end result. A few of mine. This is a 24.5 millimeter premolar. There's nothing magic about that from my perspective. I mean, this is what we deal with. It's a fairly small system in through here. No way I'm going to be able to get a heat source down to the level I want to thermoplasticize with a warm technique. So I want warm Guttapercha. My only option at that point is to do a carrier base. And you can see the two canals did join to exit a common exit. I've underfilled just below the previous amalgam to enhance the coronal seal when the permanent filling is placed. And we can see filling to the apex. So I'm pleased with that outcome. This is one that had lots of mesial distal curve, but every now and again we run into one of these upper molars that has a tremendous amount of buccal lingual curve on top of it. You don't get to appreciate how much buccal lingual curve was present in this tooth. I could get a heat source to here. That was it. So right here it's starting to curve this way, but it's also really diving to the lingual. There's no way I'm going to get a heat source down to thermoplasticize at this level. So to me this is an ideal Guttacore carrier case. Tight anatomy in an upper molar. Same thing. Guttacore case. The two canals did remain separate and distinct in the mesial root. And you can see how narrow that gets in the apical half of the root. Questions? Yes.
So is there any problem with when you're removing the carrier with like a round burr about like dislodging? I mean, do you let it sit and harden up a little bit?
I'll give it a blast of air many times. I don't want to put water or anything else on the inside of it. I will give it a blast of air to sort of start to set the Guttapercha. There's concern with dislodging the carrier, whether it's removing it with a spoon, removing it with a round burr, however you're going to remove it. So ideally, I'd love to remove it by just giving the bend on the handle, but it's a little more resilient than that. It doesn't necessarily always want to come out easily that way. It can, it will sometimes, but not each and every time. So after I give it that little blast of air, if I really engage that carrier towards the canal wall, whether it's with a spoon or with a small round burr, I have not had significant issues dislodging the carrier. Has it happened? Yeah, it definitely has. And then I put in another one.
Okay.
Because there's a reason I'm putting that material in that tooth. There's a biological indication. So I'm not just going to punt and say, okay, I'll just put in a single cone with some sealer. Okay. Right? I still want to get my carrier there because I think that's going to create the best, tightest seal in that tooth over the long haul.